Hi, everybody. This is Dr. Ronald Whitmont, and I'm going to be speaking to you tonight about homeopathy and the microbiome. And there's a lot of information on this, so I'm going to be fairly brisk in covering this material. So to begin, I don't have any financial relationships to disclose, and I will not discuss any off-label or investigational use during my presentation. Today we're going to talk about the human microbiome, and we're also going to talk about chronic disease, homeopathy, and we're also going to talk about chronic Lyme and post-Lyme disease syndrome with a case, and then we will conclude. So first we're going to speak about the human microbiome. The Human Microbiome Project, as many of you should know, was launched in 2008 by the National Institutes of Health. It's a multi-center research project using genetic sequencing technology. The human microbiome first started studying all the bacterial life on the human body, looking at several major sites, including these: the nasal passages, oral cavity, skin, GI tract, and the urogenital tract. This is where they started sampling. You can see from this schematic that each different zone of the body represents a different ecological niche. The human body is host to microbiological communities whose abundances are estimated to exceed our own cells by at least one order of magnitude. Opinions differ on this, but there are definitely more bacterial, viral, fungal organisms than there are human cells on the human body. So the collective organization of the genomes of these microbiological symbionts provide us with traits that we have not evolved with. In other words, these organisms actually fulfill essential roles that we cannot provide or do ourselves. In fact, in 1 gram of healthy stool, there are huge numbers of bacteria, viruses, archaea, human cells, and also fungal spores. Just dramatic numbers, even in a single gram of stool. This representation on the right is really what's important here, looking at the makeup of a typical human bowel movement. So the human microbiome directly influences human development, human nutrition, and immunity. The different organisms in our microbiome are part of a huge network of interconnected, ecologically interworking organisms that, since it is an environment and it is an ecology, these organisms work together to essentially allow humans to develop the way we do. We have studies that show that bacterial-free organisms just don't develop the same size, the same stature. They don't develop the same size organs that we have with the microbiome present. Symbiotic organisms basically are regulating many of our biological functions. They regulate nutrition and metabolism, and they're critical to the development of the immune system. Where do all these organisms come from? Well, in fact, we always thought that the human being was pretty much sterile until birth. And then in the birth canal, it was exposed to all the organisms vaginally and in the perineum. Well, it actually begins before birth. And it turns out that even the placenta has its own microbiome. And the interesting thing about the microbiome in the placenta is that the organisms do not represent organisms that come from the vaginal vault or even the skin. They most closely resemble the organisms that are found in the mouth. So you have a whole system of organisms that already exist prior to birth that are already influencing the development of the fetus in utero before birth. The most critical period in the development and the acquisition of the microbiome, which starts before birth and continues throughout life, is the first 2 years. And it turns out in the first 2 years of development, if there is a lack of exposure or if there is a critical loss of organisms in the microbiome, this can have profound effects throughout an individual's life. The critical exposures that we know of, as I mentioned, begin in the placenta, but also take place in the birth canal. They take place through contact with the mother's perineum and rectum as birth is taking place, and then continues through breastfeeding and breast milk. And many factors within breast milk have been found to play no other role other than to support bacterial growth in the gastrointestinal tract of the infant. Again, just to review, you should all know this, but as the child is born in the normal position, which is face down, you can see the placenta here. You can see the birth canal, and again here you have the rectum underneath. And as the baby's mouth comes down, it's going to be exposed to a whole inoculation of organisms in the birth canal, but also making contact with the mother's perineum. And of course, we tend to use povidone iodine and other detergents to sterilize or try to sterilize the birth canal, which is a mistake. And you can also guess the impact that might take place when people are born not through normal vaginal delivery, but through a C-section. And many obstetricians and gynecologists today are beginning to swab the newborns after C-section. They're beginning to swab their mouths and their faces with bacteria obtained from the birth canal and from the mother's perineum. So what we have here is the human biome and the human organism are actually part of what's known as a supraorganism. It's a communal group of human and microbial cells that work together. We don't survive very well without these organisms, and they don't survive very well without us. And as I mentioned at the very first slide, the Human Microbiome Project has had to use genetic sequencing technology to determine which organisms were present in the microbiome, because many of these organisms have still not grown outside the laboratory. So we can't even reproduce artificially the network of cells that are interacting inside the microbiome. We can't produce it in a laboratory. We're not able yet to mass produce it or to sell it to anyone else. The only way we can actually obtain these organisms is by direct sampling or by fecal transplantation. So the supraorganism is essentially a collection of different ecosystems in the body. Each place on the body actually has a different collection of organisms, and these organisms, the different ratios of different bacteria, viruses, and fungi will change even when you go a few millimeters away from one original sample spots. So as you go through particularly the gastrointestinal tract, the organisms will change as you go farther and farther along it. It is not a uniform set of organisms whatsoever. And the other part that's interesting is that the organisms change wherever you are on the body, whether you're looking at the ear or in the nostrils or in the mouth, or as I mentioned in the placenta, the organisms are different. And the same laws that govern ecosystems govern the microbiome. And that means that diversity is extremely important when it comes to a balanced ecosystem and a balanced ecology, and symbiosis, the organisms working together. And symbiosis is a crucial thing when it comes to health, as we'll find out a little later. So diversity is what actually dictates the stability of most ecosystems, and this is true with the human microbiome as well. We know that diversity is that rich and balanced bacterial communities seem to be perceived as self, and we're talking about the human gut in this circumstance, and they induce a quick maturation of the immune system and gut responses when there is a diverse collection of organisms. And when the collection of organisms in the gut is not diverse, when it's unbalanced or what we call dysbiotic, that this set of organisms actually is perceived as a foreign entity, and it induces inflammatory responses. And this is part of the newest theories now when it comes to the development and the etiology of inflammatory bowel disease and a lot of the gut-based illnesses, chronic inflammatory illnesses. So the implications of this are that the maturation and activity of the innate and adaptive immune systems are directly affected by the diversity of the gut microbiota. This is not surprising since the majority of the human immune system is actually based in the gut. So it would make sense that the juxtapositioning of all this diverse life has a direct impact upon the development of the immune system. So just to encapsulate what we spoke about here with the immune system, with the human microbiome, is that the human microbiome and the microbiome of really any animal represents a vast and diverse microbial ecology. It covers and it permeates the entire human body. There's been so much focus on the microbiome recently, and mostly it's been about the gut microbiome. But the important thing to remember is that the microbiome is literally everywhere. And we're finding places that we used to consider sterile in the body. They're just not sterile at all. And we know easily that all the orifices of the body are already colonized. That the human microbiome is actually an extension of the human genome. And what we call the supraorganism is a collection of the genomes of human cells plus bacterial, viral, and fungal entities, as well as archaea. And that these organisms are all working together, that these organisms actually outnumber us in the human body, and that one of the most important implications that we know so far about the microbiome is that it's a complement to the human immune system, and that the immune system cannot function normally without a full complement of microbiome cells. And so that begins to suggest the role of the human microbiome in disease, which is what we're going to speak about. Before we go on to that, we're going to talk about chronic disease in the United States today. We're going to review essentially what we know so far, which is the leading cause of death and disability today in the United States is chronic disease. And it's really considered the great epidemic of our times, responsible for 75% of total healthcare costs, and the majority of deaths in the United States are due to chronic disease. About half of all adults, or about 117 million people, had one or more chronic conditions in 2012, and 25% had more than one chronic condition. This is just a review of some of the chronic conditions: hypertension, coronary artery disease, stroke, diabetes, cancer. We're talking about the major killers in the United States. These are chronic illnesses. And you can see from this slide from the RAND Corporation, this is actually an old slide still. This was back in 2002, where it was only about 45% of the US population was suffering from chronic disease. You can see, again, from the RAND Corporation, that the prevalence of chronic disease has been steadily increasing, and that not only the numbers of Americans suffering, but also the percentage, I don't show it on the slide, but the percentage of American suffering has been climbing. And by 2020, it's estimated that it will be 50% of Americans will be suffering from at least one form of chronic disease. The CDC tells us that the cause of chronic disease is lack of physical exercise, high blood pressure, hyperlipidemia, these things, poor nutrition, tobacco and alcohol use. However, that doesn't cover all of what's going on. And when you look at more of the recent thinking on this subject, inflammation is one of the underlying common denominators in almost every chronic disease. And inflammation, as it says here, has long been a well-known symptom of many infectious diseases, but molecular and epidemiological research increasingly suggests that it's also intimately linked with a broad range of non-infectious disease, perhaps even every one of them. It's becoming increasingly evident that the lack of exposure to a variety of microorganisms, especially during early life, may result in the development of diseases such as type 1 diabetes, asthma, allergies, celiac disease, inflammatory bowel disease, and obesity. So this is the beginning of what we call a hygiene theory, that many of our chronic diseases are actually a result of not being exposed to enough of the essential microorganisms that are supposed to be populating our bodies. So according to the hygiene hypothesis, the decreasing incidence of infections in Western countries and more recently in developing countries is at the origin of the increasing incidence of both autoimmune and allergic diseases. And you can see from this slide, which shows on the left-hand side, is basically the incidences of things like tuberculosis, rheumatic fever, measles, mumps, diseases that we've essentially considered disappearing or eradicated. It's very interesting that it's the mirror image of what we're seeing with chronic disease in our society. We don't have a direct evidence that one is causing the other, but it's a very suspicious mirror image. As we look on the right, Crohn's disease, multiple sclerosis, type 1 diabetes, asthma, these things are just skyrocketing. And again, going back to what the CDC says about the cause of chronic diseases, so many of them don't even cover the pediatric population. You have, since 1980, the prevalence of chronic diseases in the pediatric population has nearly tripled. So that just can't be explained by the etiologies listed by the CDC. The incidence of skin and food allergies has nearly doubled between 1997 and 2011. And studies using animal models of allergy have provided direct evidence that the microbiome provides protection against allergic disease, allergic responses and allergic conditions. And that basically they've looked at animals that have been depleted in their microbiomes have been depleted, and they're much higher risk and rates of allergic conditions. So we also know that a lifestyle that's characterized by high hygienic standards and excessive use of antibiotics, as well as the consumption of highly processed foods, have been associated with a high incidence of allergic diseases. And again, each of these are factors that either reduce or limit the development of the microbiome, particularly within, as I said, those first 2 years of life, which are crucial. An interesting study done in anthroposophically raised children. As you know, anthroposophically raised children use homeopathic medicines, albeit in low potencies, but they do show a lower prevalence of atopy than those children raised in similar families, but from conventional homes. The other factors that are known about in these conditions are there are fewer vaccinations, fewer antibiotics given, higher levels of probiotics in the diet through naturally fermented foods that are part of the regular diet in anthroposophic homes. They also tend to live, not always, but they do tend to live closer to the farm. So a very interesting case study of one of the childhood chronic diseases is asthma. And we know that asthma is the leading cause of chronic illness in children today in the United States. It's also one of the fastest growing conditions of any developed nation. Between 1980 and 1994, the total number of children suffering from asthma increased 75%. But those children younger than 4 saw an increase of 160%, which is quite astounding. When you, again, go back to what the CDC is saying is causing these inflammatory conditions. It's not what they say. Asthma is the #1 cause of hospitalization. There's a 66% higher death rate in asthmatics since 1980, so it's getting deadlier. It affects more than almost 5 million children, or 1 out of every 15 kids in the United States. Well, what's really interesting about this, when you want to talk about etiologies in the microbiome, is that when this was a research article published in Chest, they found that when 1 to 2 courses of antibiotics are given in the first year of life, the risk of asthma increases by 20% by age 7. 3 to 4 courses increase the risk by 30%, and more than four courses of antibiotics increase the risk of developing asthma by age 7 by 50%. The risk of asthma was highest in children receiving more than 4 courses of antibiotics, and broad-spectrum cephalosporin use was the most common denominator in these populations of children. So the broader the spectrum and the more courses of antibiotics that the child receives in the first year of life, the higher the risk of developing asthma. The adjusted odds ratio for this, actually this is for another study published in Clinical and Experimental Allergy. The odds ratio was 4.05 if antibiotics were used in the first year of life, compared to only 1.64 if antibiotics are used after the first year. So again, a crucial time in developing the microbiome is that first year. The use of antibiotics in the first year of life is associated also with an increased risk of rhinoconjunctivitis and eczema, in addition to asthma. And that's supported again by that, that study on anthroposophageal children. So one of the most recent bits of information I came across was even the antibiotic use during pregnancy is now been found to be associated with an 89% greater risk of childhood asthma. Quite significant. This was a report from the American College of Allergy, Asthma, and Immunology. I don't know whether it's been published yet. I haven't seen it published anywhere yet, but it's quite remarkable. So this is saying that the mother's microbiome may be playing a role as when you limit the mother's microbiome, that's going to limit the child's microbiome by extension, and that's going to predetermine the risk of allergy and asthma, which is quite significant. Very briefly, I just want to touch upon when we're talking about the microbiome, we're not just talking about antibiotics, we're not just talking about the bacteria. We're also talking about beneficial parasites, we're talking about viruses, and we're talking about fungi. And all of these organisms play a role in the microbiome. Some of them, there's been much more research done over the last few years on beneficial parasites, particularly hookworm infection. And they have found that hookworm infection is strongly associated with a reduced risk of developing asthma. And when you deliver the hookworm ova to people who already have asthma, you often see a reduction in asthmatic symptoms. So there's a parasite, it invades the gut. We're not talking about a deadly parasitosis, but it's really a benign parasite that we've seen almost eradicated again today because of the super hygienic standards that we practice in first world societies. Also, whipworm therapy has been found to be extremely beneficial in inducing remissions of active ulcerative colitis. And there's been extensive research on this over the last 20 years, looking at, again, the parasitic worms that do not cause, they do not cause pathology. They are basically commensal organisms that we may have evolved with, and they may be extremely important in reducing inflammation and allergic conditions. This brings up some really important data that came out of Sardinia, Italy, back in the 1940s. Sardinia, as you all know, is an island ecosystem, and malaria was introduced to Sardinia about 502 BC. And but during the incidence of malaria in Sardinia was actually quite devastating to the population at one point. And this induced the Rockefeller Foundation to conduct a large-scale malaria eradication project between 1946 and 1950. And to accomplish this, they literally delivered 267 metric tons of DDT that they spread over the island. They went into homes and they sprayed DDT. They sprayed it in lakes and rivers, and they were successful because they entirely eliminated malaria from the island. This is just a quick photo of one of the teams that was working to eradicate malaria. So the interesting thing here is that malaria cases, you can see from the year 1946, the number of cases was drastically reduced. And by 1952, there were no more cases of malaria being reported. So this is a great success story of modern science over an illness. Now it would all end there if it weren't very much more interesting because of what happened to the microbiome and what happened when this parasite, this malaria parasite, was eradicated from the immune systems and from the bodies of the native population of Sardinia. We saw the incidence of multiple sclerosis emerge out of the background. It was not even tracked before 1946. But by about 15 years later, in 1965, we saw the incidence of multiple sclerosis basically make it onto the map. By 1995, it had increased, 500%. And then by the early 2000s, it had increased again. It had doubled from the last figures. And now multiple sclerosis, there's the highest incidence of multiple sclerosis in Sardinia as anywhere else in the world. Even comparing it to the United States, the incidence in Sardinia is easily twice as common. And the prevalence is twice as common. So what happened here? We had a stable population where there was a parasite. The parasite and the immune system were in some form of negotiation. The parasite was eradicated, and now you had an immune system that was missing part of the ecology of its system. And this commensal relationship was destroyed. And now you have an overactive immune system and an autoimmune disease as a result. And many people have looked at this phenomenon and concluded, this is just one conclusion, saying that a dramatically rapid change of the environment after the eradication of malaria has led the Sardinian immune system to abnormal responses, favoring increased MS incidence over the last 4 decades in Sardinia because of the eradication of malaria 50 years ago. And again, eliminating a stable commensal parasite or changing the microbiome alters the phenotypic presentation or penetration of a disease of immune dysfunction. So again, this is talking about how does the microbiome, if we upset the microbiome enough, we can create autoimmune diseases. We can create allergic diseases. We can create inflammatory conditions, okay? From the New York Times, which is one of my favorite science sources, we've just spent the better part of a century doing our unwitting best to wreck the human-associated microbiota with a multi-fronted war on bacteria and a diet notably detrimental to its well-being. And this is absolutely true. We have to stop looking at medicine as a war between invading pathogens in our bodies. And as you know, because of the germ theory of medicine, this is the MO of conventional medicine. And the microbiome is bringing to light probably one of the greatest missteps of conventional medicine. And that is this idea that you have to eradicate germs, that the only good germ is a bad germ, and that we should be fighting a war against bacteria and viruses. And this is simply false information. And the science of the microbiome shows us how wrong this is. So the germ theory of disease turns out to be a gross oversimplification. And this is a writer in Lancet who said it accords with the basic facts that infection without an organism is impossible and that transmissible organisms can cause disease, but it does not explain exceptions and anomalies. And you must conclude those anomalies if you really want to understand what's happening today in chronic disease. So it also raises important considerations. One, that infections may not always be harmful. They may not always be bad. And that infections may actually play important roles in the maturation of the immune system and the diversification of the microbiome. So again, when you have eradicated diseases, when we have given vaccinations so that diseases are no longer even part of our cultural or our microbiome genomes, the diseases aren't there anymore, we have altered the microbiome. Infections benefit the developing immune system, and they help diversify the microbiome. This plays right into what we know about homeopathy, because homeopaths don't try to eradicate the organisms. Homeopaths try to get the organisms and the immune systems to work better together. From Scientific American, it goes against dogma to think that bacteria would make our immune systems function better. But the picture is getting very clear. The driving force behind the immune systems are the commensals, the organisms, the microbiome, the diversity, the ecology of the body. Infections challenge the immune system and the microbiome to develop tolerance and diversity. Without tolerance, we would be allergic to everything. And tolerance seems to develop the earlier you're exposed to something, the more likely your immune system is going to develop tolerance. And particularly in that first year of life, tolerance develops to nearly everything that the developing organism is exposed to. Diversity, as I mentioned already at least once, plays a huge role in the way that the immune system works. Infections challenge the immune system and the microbiome to develop immunity. And without having the chance to engage the immune system in an active infection, the immune system really can't develop the skill to develop immunity. And it also can't determine what is an appropriate level of inflammation and what is an inappropriate level. If it's not resolving the infection itself, if an antibiotic is given every time an infant has an infection, the immune system cannot learn regulation. So we know, this is from Goodman and Gilman's Pharmacological Basis of Therapeutics. This was the textbook of pharmacology when I went to medical school. I don't know how many other people saw it, but antibiotics affect various host immune responses adversely, including leukocyte chemotaxis, lymphocyte and monocyte transformation, antibody production, phagocytosis, and the microbicidal action of PM polymorphonuclear leukocytes. So again, you have another effect of antibiotics. Not only does it affect the microbiome, but antibiotics will directly affect the immune system and the function, the efficiency and function of the immune system. And Goodman and Gilman said, well, the clinical significance of this immunosuppression is not known, and this, again, is back in 1985. No, they didn't know back then, but these observations should help discourage the indiscriminate use of antibiotics. Well, so much for that. So antibiotics, we know, inflict considerable collateral damage to the immune system that can sometimes require years to recover from a course of antibiotics. We know that antibiotics, as targeted as we like to think they are, they're constantly destroying beneficial organisms as well. And actually, 99.9% of the organisms on our bodies in a healthy state are beneficial. So we know that antibiotics temporarily suppress acute inflammation via non-antimicrobial effects. So this is talking about another effect of antibiotics, which is they also reduce inflammation. Okay, they have direct anti-inflammatory effects that are not related to the antimicrobial effects. But inflammation is a part of immune system functioning. So when you are working against inflammation, you're also working against the immune system. Antibiotics are associated with an increased risk of chronic inflammation, recurrent infections, and cancer. And there was a study published in JAMA a few years ago, in 2004, demonstrating the relationship between multiple courses of antibiotics and the risk of developing breast cancer. And there's a direct correlation. Antibiotics alter the immune system, they alter the microbiome, they contribute to the development of chronic inflammation, and they definitely promote dysbiosis. And you all know what dysbiosis is, but it's the opposite of symbiosis. It's not organisms working together, it's organisms working at odd ends to each other, in conflict. It's an ecological imbalance between organisms within the microbiome. So dysbiosis, a urinary tract infection, is a dysbiosis. A skin infection is a dysbiosis. An ear infection is a dysbiosis. And it turns out many more things are dysbiotic as well. But a dysbiosis can occur anywhere on the body, and it inevitably triggers inflammation. A dysbiosis in a healthy body will trigger an immune response, which is inflammation. And we know that antibiotic use is the single most common cause of dysbiosis in our society today. So on an acute level, dysbioses are important because they trigger an adaptive immune inflammatory response. Urinary tract dysbiosis will trigger the production of white blood cells, pyuria, inflammation, pain, a way of getting the immune system's attention, which can then trigger a response that can fight the infection. That's the role of a dysbiosis on an acute stage. It triggers an illness, it triggers an inflammatory response, and it can trigger then a resolution and then an immune system maturational step. On a chronic level, there's the connection between dysbiosis driving chronic inflammatory disease. And an example of this is something like ulcerative colitis that has been found to be, when you look at the stools of individuals with inflammatory bowel disease, they're extremely dysbiotic. The bacterial imbalances are remarkable and severe. And incidentally, when you replace them, there have been studies looking at fecal transplantation in cases of severe inflammatory bowel disease, and a certain number of cases do succeed. I don't believe it's as high as treating pseudomembranous colitis or C. difficile, but they do show favorable responses to fecal transplantation when you use the fecal matter donated by a healthy host. So there's growing evidence that dysbiosis of the gut microbiota is associated with the pathogenesis of both intestinal and extraintestinal disorders. And as I mentioned, the intestinal disorders include inflammatory bowel disease, irritable bowel, celiac disease. These are typically related to dysbioses. And the extraintestinal disorders include what we mentioned already also: allergy, asthma, metabolic syndrome, chronic fatigue, cardiovascular disease, autoimmune disorders, and obesity. Essentially, we're talking about what will probably be revealed as the whole gamut of chronic inflammatory conditions are extraintestinal disorders related to dysbiosis. As I mentioned, fecal transplants, they have demonstrated benefit in both intestinal and extraintestinal manifestations of chronic inflammatory illness. And this is really important, particularly since the FDA has essentially put the kibosh on fecal transplants for anything but Clostridium difficile. It's not clear why they have done this, but it's really difficult now to even recommend a patient for fecal transplantation. They have to do it themselves. They have to look online for how to do it. There are offshore clinics that are doing this already, but not in the United States. So to review chronic disease before we move ahead. Chronic disease, we know, is the leading cause of mortality and morbidity in the United States today. It represents a state of chronic inflammation, and it appears to also be related to dysbiosis. It is generated by dysbiosis and or it causes dysbiosis as well. So let's move ahead. I'm going to talk about homeopathy. So this is set up, you guys all should know this, but homeopathy is a 200-year-old system of medicine used by more than 500 million worldwide, based on clinically acquired empiric evidence corroborated by thousands of practitioners worldwide verifying the actions of different medicinal substances in living systems. Homeopathy is based on observed, reproducible phenomenon originally interpreted within a vitalistic, spiritual, conceptual framework common in the 18th century. Homeopathy came about at a time when nobody knew what bacteria or a microbiome was. Iris Bell says, ironically, one of the most controversial systems of alternative medicine, homeopathy, could turn out to be one of the oldest and demonstrably safest forms of nanoparticle-based treatment already used worldwide for infectious diseases. And this is crucial. So why? We're going to shift gears here and talk a little bit about homeopathy and infectious diseases, because infectious diseases is usually where we run into problem with the microbiome and conventional medicine. So homeopathy has been proposed as a form of adaptive network nanomedicine. It's a lot of words. But essentially, we know that homeopathy appears to work by strengthening host defenses rather than by destroying infectious agents. And again, crucial when you're talking about balancing a microbiome rather than making it dysfunctional. So homeopathy has demonstrated observable nanoparticle forms of the source material and silica that they exist in all homeopathic potencies. That nanoparticles measure between 1 and 100 nanometers in diameter. They can either be formed by the top-down milling process, which we know of homeopathically when we triturate substances in milk sugar, or from the bottom-up assembly process, and that's usually a synthetic process that generates nanoparticles as well. And that's basically a scientific method of generating them. We know that nanoparticles actually exhibit superior antioxidant properties than the respective bulk forms. So when you look at specific antioxidants like curcumin, the nanoparticulate forms of curcumin are actually much higher in antioxidant properties than the bulk form or the gross grams of curcumin. And this is true across the board with nanoparticles. They're more effective drug delivery vehicles than conventional bulk form drugs. This has been studied. We know this because they seem to reach their selective targets more efficiently. They reduce the total dosage that's needed, and they also cross the blood-brain barrier, all of them, because they're so small. Nanoparticles have, and nanomedicine has distinct advantages over conventional bulk form agents. Nanomedicine targets specific cells and can target cancer cells while leaving host normal cells completely unaffected. The doses of nanomedicines persist longer in the body and in the cell than do conventional medications. And the therapeutic effects can be magnified by as much as 1,000 times when they're utilized in nanoparticulate form. So there's this hormetic process of a nonlinear response when it comes to the size of particles. That it actually ends up going up and being magnified when you look at nanoparticles, which is really quite not surprising for most homeopaths. So nanoparticles can select for certain cellular processes, and we know that nanoparticulate forms of medicine can directly induce apoptosis or cell death. They can be anti-inflammatory, they can lead to antioxidant effects, and extremely important, they're immunomodulatory. So these are things that we know that homeopathic medicines are capable of, and we know that nanoparticulate medicines are capable of the same thing. So nanoparticles have reduced side effects, they have greater efficacy, and they have lower costs. At high doses, we know that nanoparticles trigger strong pharmacological effects, and at low doses, they mobilize non-pharmacological biological adaptation, hormesis, and endogenous amplification mechanisms. So this is all, again, that nonlinear response between a pharmacological response at high doses and not a pharmacological response, but a completely biologically adaptive response. So here again, you have an understanding in the nanoparticulate form that these agents are actually helping the body adapt. They're helping the organism rather than killing a disease or killing a bug. Nanomedicine supports the patient's adaptive networks, leading to functional self-reorganization of the patient as a biological network. The result can be host expression of a more robust cellular defense system against infections and other stressors. So to briefly review, I want to touch on the homeopathic experience in several epidemics and conditions that we have actually looked at today. So historically, homeopathy has been found to be effective in many epidemics, including these: malaria, influenza, scarlet fever, and cholera. But also in more modern evaluation, homeopathic preparations of Eupatorium and Arsenicum album have been found to be effective against the Plasmodium malaria. And in vivo, these medicines have demonstrated significant inhibitory effects on the actual parasite multiplication. Leishmaniasis, in vitro and in vivo studies in mice demonstrate homeopathic treatment modulates experimental infection and controls infection progression and limits the dissemination of leishmaniasis. Homeopathic medicines have antiviral effects, both in vitro. Well, in vitro here, when looking at the human pathogenic enveloped and non-enveloped RNA and DNA viruses, significant reductions in infectivity have been noted in these viruses: human herpes 1, human adenovirus C, serotype 5, influenza A, human respiratory syncytial virus, human parainfluenza virus 3, human rhinovirus B, serotype 14, and human Coxsackie, serotype A9. And this is an in vitro study looking at homeopathic medicines on the viral infectivity of these organisms. Even HIV/AIDS, a group of studies found that specific physical, immunologic, neurologic, metabolic, and quality of life benefits, including improvements in lymphocyte counts, functions, and reductions in HIV viral loads and HIV/AIDS result from homeopathic treatment. So this is all to say that there is concrete evidence that homeopathic medicines contain nanoparticles. There is evidence that both nanoparticles and homeopathic medicines work in infections, and they stimulate host adaptive responses. And there's even laboratory evidence of in vitro effects of these agents. We're all aware of the leptospirosis homeoprophylaxis program that took place in Cuba with 2.3 million people exposed to, given the leptospirosis homeopathic product, which was made from 4 circulating strains of leptospirosis. And it demonstrated a significant reduction of disease incidence found in the intervention regions, with an increased incidence observed of disease in the areas that did not receive the homeopathic prophylaxis, and that the intervention region incidence fell below the historic median, which was These were all significant findings. A trial of influenza looking at, it was a placebo-controlled trial with 478 participants, and comparing homeopathic treatment with placebo. And the homeopathic group demonstrated a 17% response rate within 24 hours versus a 10% response rate, within 48 hours. Another study looking at otitis media in a prospective observational study with 131 participants using homeopathic versus conventional care. Not using placebo here, but conventional care. The population age varied between 6 months and 11 years old. And the homeopathic group demonstrated a shorter duration of pain, 2 versus 3 days, a shorter duration of treatment, average 4 days versus 10 days, because antibiotics were frequently used and they were not stopped before 10 days. A 1-year free of recurrence rate of 71% in the homeopathic group versus 57% in the conventionally treated group, and fewer recurrences. 29% of the homeopathic group had a maximum of 3 recurrences versus 43% of the conventionally treated group had a maximum of 6 recurrences. So you see benefits across the board with homeopathic treatment of otitis media. As we know, diarrhea studies done on different populations looking at 3 double-blinded trials of 242 participants, and the homeopathic treatment group had a shorter duration of childhood diarrhea. Finally, looking at chronic disease using homeopathy at a 24-month follow-up study with almost 4,000 participants. 97% of them suffered from one form of chronic disease or another, and disease severity was decreased significantly in the homeopathic treated group. Actually, the entire group was treated homeopathically. Disease severity was decreased significantly in this group, and this was the case in adults, mostly adults and young children, showed the majority of improvements. And the factors that were found to relate most closely to benefit from homeopathy were younger age and more severe disease at the baseline, which is remarkable. This is not what you would expect even from placebo, that those who have the more severe disease at the baseline have had the greatest benefit from homeopathic treatment. Again, chronic disease, the same group was extended to follow up to 8 years. We're at about 3,700 people right now, still 97% with chronic disease. And these are the most frequent diagnoses that were listed in the study group. So it does cover a gamut of chronic illnesses, everything from asthma to high blood pressure, eczema, anxiety, the whole range. And again, disease severity was significantly decreased in this group. And now they're finding that not only was younger age, but female gender and severity of disease were the factors that were most predictive of a response to homeopathic medicine. I'm sure there's some good theories of why female gender would contribute to that, but I can't think of what they are right now. So, the microbiome. Homeopathic potencies are capable of completely altering the bacterial flora of the bowel. And we don't have current research on this topic, and this is really what we need. But when we go back to John Paterson, who, along with Edward Bach, gave us the bowel nosodes, they found that these medicines, actually homeopathic potencies in general, altered the bacterial flora. They didn't know it was the microbiome, but they saw changes in the balance, in the diversity. They saw changes in the different organisms that were found in the stool of those people who were treated pre and post with homeopathic medicines. So again, just to reference the bowel nosodes, these are medicines prepared from non-lactose fermenting bacterial isolates from the human GI tract, developed by Dr. John Paterson and Edward Bach at the Royal London Homeopathic Hospital between 1920 and 1960. We need much more research in this area. A review of the bacterial bowel nosodes that we know of, that we have already, and the suspected organisms that they are related to, or that actually comprise those nosodes. To briefly review what we're talking about homeopathically, so we know homeopathy is an empiric science. It is a biologically active form of nanomedicine, and we know it's effective in a wide range of infectious and chronic diseases. We are beginning to suspect that it can have profound effects on the human microbiome. We have very limited research that supports that right now, and we need more of it. So we're going to move on to the next topic, which is our last topic, and this is chronic Lyme disease. I can pause here for a second if there are any questions from the group. Okay, we'll go ahead. So chronic Lyme disease is a diagnosis based solely on clinical judgment. And it's not based on well-defined clinical criteria. It's also known as post-Lyme disease syndrome. It's a diagnostic term used in North America and Europe for patients with persistent pain, neurocognitive symptoms, fatigue, or all of these symptoms, with or without clinical or serological evidence of previous early or late Lyme disease. But there's nothing that we can use to diagnose chronic Lyme disease. And in fact, this article in New England Journal of Medicine is the thrust of this article, the thesis is that chronic Lyme disease does not exist. It should be called post-Lyme disease syndrome. So despite the resolution of the objective manifestations of infection, namely the blood tests after antibiotic treatment of Lyme, a minority of patients go on to develop fatigue, musculoskeletal pain, difficulties with concentration or short-term memory, or all of these symptoms. And once the diagnosis is made, patients are commonly treated for months or years with multiple antimicrobial agents. But studies looking at the benefits of these treatments don't find any. That there have been no significant differences between the clinical responses of patients who received intravenous and oral antibiotics for 90 days and those who received placebo. There may have been short-term benefits. There may even have been long-term benefits, but the benefits did not differ from those given from placebo. Even in basically in Lyme encephalopathy, IV ceftriaxone therapy results in short-term cognitive improvements for patients with post-treatment Lyme encephalopathy, but relapse in cognition occurs after the antibiotic is discontinued, and this is uniform across the board. So a post-Lyme disease encephalopathy does not respond. It may respond temporarily to intravenous ceftriaxone or rocephin, but there's no long-term effects. There's a question that says, do I use probiotics in treatment of Lyme disease? I recommend probiotics to my patients with almost any condition. But the problem with probiotics is really quite simple, that we don't have the right probiotics yet. And one of the things I didn't mention when talking about the microbiome is that the human microbiome is made up of over 10,000 different microbial species, not different organisms. We're talking in the hundreds of trillions of different organisms, but over 10,000 different species. The average probiotic that you'll purchase at a health food store, or even the best probiotic, won't have more than 15 to 20 different species. As I mentioned, they had to use, the scientists in the Human Microbiome Project had to use genetic sequencing technology because these organisms cannot be isolated and they can't be grown outside of the human intestine. They will not survive. They can't reproduce. We haven't found the right growth medium. We are the right growth medium. The human body is the growth medium for the human microbiome. And the only way you can really provide the correct probiotic substitution for these patients is to give them a fecal transplant. That's the only way you really can do it. It may be possible, maybe that technology will exist in a few years, but it doesn't exist today. Okay, I hope that was clear. So in chronic Lyme disease, there is a substantial risk with little or no benefit associated with the additional use of antibiotic treatment for patients who have long-standing subjective symptoms after appropriate initial treatment for an episode of Lyme disease. So this is essentially saying there's no benefit from using antibiotics in chronic Lyme disease or post-Lyme disease syndrome, and antibiotic therapy can cause considerable harm to patients. And this is not even referring to the harm that the antibiotics induce to the microbiome, which is a whole nother story. So what's causing chronic Lyme disease? Well, we have to begin to suspect that chronic Lyme disease or post-Lyme disease is at least in part related to chronic dysbiosis. That certain individuals are going to be more susceptible, maybe through genetic mechanisms, but there's a lot of dysbiosis already going on in chronic Lyme or post-Lyme disease syndrome patients. So dysbiosis, how do you treat dysbiosis? Yes, a fecal transplant would be wonderful, but we also have homeopathy. So chronic Lyme, most cases are remarkable for histories of repeated and prolonged overuse of antibiotics that antecede the acquisition of Lyme. Now, in my practice, when I take someone's history, it's relatively common. In fact, I would say it's the rule rather than the exception that people describe years of use of antibiotics, beginning in infancy, sometimes just extending for years when they use antibiotics to treat their acne or to treat recurring urinary tract infections. But you almost inevitably see that there's a long-standing history of antibiotic overuse. And sometimes it dates back to childhood. And those patients who end up with chronic Lyme disease almost inevitably have this history. So I'm going to go through a case here of post-Lyme disease syndrome, chronic Lyme. This is going to be not sophisticated. This is a real simple case. And so this is not going to be rocket science because that's not what I do. So this is a 92-year-old Caucasian male. He was a retired physician, and he presented to me with complaints of chronic Lyme disease. He told me that he had had multiple tick bites over the previous year, and he lived in the Northeast United States, which is a Lyme endemic region. So that's all we really need to know. He did have Lyme disease. He was initially treated not by me, but before he came to me, he received doxycycline for a 28-day course, 100 milligrams twice a day, followed by an additional 26 days of cefdinir. Initially, he showed improvement in his symptoms while he was being treated, followed by a relapse and worsening of his symptoms shortly after discontinuing the antibiotics. Now, I want to remind you about a slide I showed earlier that demonstrates that there are non-antimicrobial effects of many antibiotics that are anti-inflammatory. And doxycycline is known to produce anti-inflammatory effects that have no relationship to their antimicrobial effects. And this is really crucial because here you have a person who felt better while they were being treated, but shortly after treatment, shortly after the anti-inflammatory and antibiotic treatment was discontinued, they felt worse again. At the time of his visit with me, his main symptoms included brain fog, depression, vertigo that was worse in the morning after rising, nausea with an intolerance of spicy and fatty foods. He preferred warm environments, fresh air. He experienced clicking sensation in his neck, night sweats, fatigue. It took him great effort to do even desk work, and he hadn't been outside in the previous 2 months. Generalized weakness and lack of energy. His medical history was really remarkable because well, let's not get there yet. He had also multiple urinary complaints, including chronic urinary retention, hesitancy, incontinence, nocturia. And he'd recently been treated again with an antibiotic, this time ciprofloxacin, for a urinary tract infection. But this was the important thing. He had a long history of frequent and recurrent antibiotic use. He was a physician. He had ready access to any antibiotic he wanted, and every time he felt a cold coming on or a sinus infection coming on, guess what he would turn to? I wish this were uncommon. He also had a history of inflammatory bowel disease and gastroparesis. Chronic recurrent sinusitis, again, treated repeatedly over the years with antibiotics. A hiatal hernia and osteopenia. Degenerative disc disease of the spine. He'd had prostate cancer. He's status post-radiation chemotherapy. And he had a triple abdominal aortic aneurysm. Not treated. So his physical examination, a tall, thin, frail Caucasian male. He appeared older than his stated age. Had pectus excavatum, a very narrow chest, pale skin, no apparent distress, and his vital signs and physical exam were otherwise unremarkable. So my assessment was, 1, antibiotic overuse and abuse with evidence of chronic dysbiosis. There's no way this guy did not have chronic dysbiosis. And several of the ways that we know it manifests is inflammatory bowel disease, chronic sinusitis, which is one of the fastest growing chronic conditions in adults in the United States, or maybe the most prevalent, and chronic Lyme disease, or what we're calling post-Lyme disease syndrome. This is dysbiosis related. His dysbiosis may also have contributed to chronic malabsorption. Wouldn't be a surprise. We know that the microbiome plays a huge role in the nutrients that we absorb and the way we absorb them, and even the nutrients that are generated in the gastrointestinal tract depends largely on the diverse array, of microorganisms that are on the body and in the GI tract. So chronic malabsorption in this case is going to lead to osteopenia and probably fatigue, again, related to dysbiosis. Therapeutic intervention, I'm not going to go into how I chose it, but I selected Gaitner bacillus. You got 1 single dry dose of 200 C by mouth. Just a reminder for those who are not homeopathically trained that our prescriptions, our classical prescriptions, depend upon the total clinical pattern of biopsychosocial symptoms, relies upon the individual salience, and the state dependency of the host. Again, this is not a treatment that's meant to kill organisms. This is a treatment that's meant to assist the biological adaptive mechanisms of the host. So it's state dependent on the host, and it's dependent upon the individual salience, or what we mean by that is the individual characteristics of that person have to dictate the prescription of the medicine. Well, what do we know about Gaitner bacillus? It's a bowel nosode. It may be salmonella related. The keynote is nutrition. This gentleman suffered from a lot of nutritional deficiencies. Clinically, it's useful in nutritional disorders common to children, those fed on artificial food who have poor digestion, but it could also be completely appropriate in someone in the elderly population who's suffering from chronic malnutrition. In the digestive tract, Gaitner bacillus is related to the inability to digest things like fat. It can be connected to celiac disease, ketosis, intestinal infantilism, malabsorption, either from lack of adequate diet or failure to metabolize. Again, that's the microbiome, failure to metabolize or absorb. Okay, microbiome is huge in this area. It's indicated clinically by emaciation, marasmus, particularly in children, the elderly, or those with malignant disease. Gaitner can be associated with growth disorders, poorly nourished bodies, and poor muscular development, but generally with active mental and active minds. Restlessness with lack of attention. In the 1 month follow-up, he said he was doing much better. His nausea at this stage was mild. It was worse in the morning after rising and better by noon. His vertigo was only once in a while, usually with nausea. He still feels his head isn't level. He's not even keeled, but his nocturia has improved. At that point, he received phosphorus 200C, and this was based on constitutional symptoms. What we know about phosphorus, again, extremely briefly, extremely superficially, trituration of red amorphous phosphorus. It irritates, inflames, degenerates the mucous and serous membranes of the spinal cord and nerves. It causes paralysis. It destroys bone, especially in the lower jaws and tibia, disorganizes the blood, causes fatty degeneration of the blood vessels in every tissue and organ of the body. So phosphorus, people tend to be oversensitive, excitable, impressionable, anxious. They can be spacey. They can't keep their minds on any single subject. Depression can arise from a belief that they have an incurable illness or disease. There is a constitutional body type, tall, slender, narrow-chested, tubercular patients. It did happen to fit this patient superficially. They tend to have experienced full bladders without urging. They tend to have burning and twitching in the urethra, frequent desire to urinate, frequent urination at night, vertigo with faintness, nausea, headache, vertigo floating sensation on waking, vertigo after rising, better open air, profuse sweat at night. These are all symptoms that my patient had, and these are all patients that can be found in phosphorus. There are many more symptoms of phosphorus. These are the ones that were demonstrated by my client. At 3-month follow-up after the phosphorus, he said, I'm very pleased with the last 6 weeks. I've noticed a gradual improvement in energy. There's been no nausea, no gastrointestinal distension anymore. And this is a man who had gastroparesis when he started. He had no recurrent sinus or urinary tract infections at that stage. The vertigo had resolved. The brain fog had resolved. There was no more urinary incontinence. And he said his biggest concern was, how do you discourage old friends from staying too long? At 1 year, there were still no recurrences of his symptoms. He feels strong and fit, and he said, I'm doing very well for 94, and I have no complaints. If I continue how I am, I will be very satisfied. So, chronic Lyme disease. It seems to be a diverse collection of symptoms. There is continued antibiotic administration is not helpful, and it's potentially extremely harmful for a number of different reasons, including its effects on the microbiome. I would urge anyone looking at chronic Lyme or chronic post-Lyme disease syndrome to consider it to be a dysbiosis. So now we're just going to conclude. I'm going to remind you a couple things about what we talked about tonight. The microbiome is profoundly affects the immune system and the tendencies to develop chronic inflammatory disease. Homeopathy, as one of the earliest forms of nanomedicine, has a clinical track record of success in both infectious and chronic inflammatory conditions and may act directly on the microbiome. We need research to demonstrate this. Further investigation of homeopathy, nanomedicine, and its impact on the microbiome is definitely warranted. And finally, rather than rejecting, this is from Iris Bell again, rather than rejecting the entire field of homeopathy for its originally vitalistic interpretations, it's time for modern scientists to examine seriously the nanomedicine implications of Hahnemann's empirical findings for integrative healthcare. Are there any questions?
Hey, Ron, Tim Fior from Chicago.
Hey, Tim,
great presentation. Good. Great presentation. So interesting case that you presented. Can you comment just like generally on when you would consider bowel nosodes to start a case with a bowel nosode? I know that I have repertory, and you can limit it to things and maybe have the bowel nosodes show up in your repertorization and such. But when is it just if you're suspecting dysbiosis that you would consider it, or how do you use the bowel nosodes to start a case?
That's a good question. Thanks for asking that, Tim. A couple of different things will lead me in the direction of the bowel nosodes. And yes, the first thing that probably raises my flag when it comes to the bowel nosodes is an extensive history of antibiotic overuse and abuse. And so when I see that, that puts it on the radar for me. And as you already noted, the bowel nosodes are extremely underrepresented in most repertories. So it's really hard. You're not going to come across a bowel nosode in 99.9% of your repertorizations. So you have to go out of your way to think about it. So I think about it when I see a case that just shouts dysbiosis. I think, okay, what would be an appropriate bowel nosode to use here? And I don't always start with the bowel nosode. In this particular case, I did, and I think the other thing that makes me start with a bowel nosode, which is relevant here, is that if I'm taking a case and I'm just not tremendously happy with either the constitutional or the acute remedy that I've come up with, and I'm just kind of going, yes, this guy seems like a phosphorus, but I just, it really didn't, when I first took his case, I really wasn't convinced that phosphorus was his remedy. So the bowel nosode enabled me to start and gave me some more time. And I know that when Russell Malcolm taught us the course called Systems and Symbiosis about the bowel nosodes a few years ago, he mentioned using bowel nosodes to open a case to be followed up by the constitutional medicine, usually within a couple days or a week at the most, that you would use initially the bowel nosode. You'd send the patient home with the constitutional and say, you'll take the bowel nosode for a day or two, and then you switch over. I've played around with different techniques, and I think the one that I like now and the one that I use more commonly is closer to this case, is that I'll give them the bowel nosode only in a case of severe dysbiosis, and I'll wait. And if I don't see a response, I'm actually pretty surprised. But then I'll then step in with either a constitutional or whatever the indicated remedy choice would be from the repertory.
Thank you.
Yes, you're welcome. Any other questions? Well, thank you very much. I hope that was helpful, and I hope it was informative as well, and in presenting some of the latest data on the microbiome and also correlation with homeopathic treatments. Thanks very much.